We'll start with our first keynote speaker, Dr. Adrian Hernandez. I've known him for a few years. He's a professor of medicine and cardiology at Duke. He has a long list. I have several pages here, so you can sit back down again if you like. He's a long list of accomplishments. He's currently the Director of Health Systems and Outcomes Research at Duke Clinical Research Institute. He focuses on CV outcomes and is also a driving force, along with Greg Fonero, on the Get With The Guidelines, which we've tried to model a lot of our Canadian initiatives after. And so he's going to speak about reducing the burden of hospitalization for heart failure, and it'll be a very interesting talk. Adrian.
All right. Well, thanks. It's great to be here. And one note in terms of the title is I added a question mark because I'd say we're still unsure about how to do this. And so I think part of the interest, especially for this center, is how do you bring forces together to actually reduce the burden of heart failure and the hospitalization. So here are my disclosures. So I guess there are a couple key questions that I have for us before we start. So I hear that Toronto is a great place for healthcare, and this is a terrific place for patients, and everyone should come here because it gives ideal care. At Duke, we like to think that we give perfect care, and then sometimes when we actually look, we recognize we're not quite as perfect. We like to think that we're better than our rivals, University of North Carolina and Chapel Hill, Tar Heels, both in basketball as well as heart failure, but sometimes we're just average. So just with a show of hands here, do you deliver perfect care? People think here that we deliver perfect care. Okay, well, it looks like we still have some room for improvement, so that's good. So everyone has some jobs here in the room. And then the next is, what do patients expect? Do they need more information? Do they have everything at their hand that would help them make decisions? Because nowadays they have many choices. And how do they get that information? They maybe talk to their friends, their family. Maybe they even actually look at Google. Has anyone had any experience or knows either a family, a friend, or a patient that's looked at Google for getting the best care? I'd say probably a lot of people. Well, it turns out that's right. The one thing, though, it's kind of sad, though, is that when you actually look at analytics such as when people pose questions in search engines like Google, it turns out that physicians, they stop at the top 3 hits. They don't go do any deeper dives. Patients, on their hand, go and do deeper dives. They go pages after pages after pages to actually try to find better information. And so I think this is something we also should think about in terms of how do we actually enable better information to patients, because they're really searching for answers. But then also, how do we get clinicians to actually recognize what would be the best answers and get that information as they're delivering care? So I'm just going to talk on a few broad topics in terms of efforts towards population health. In the U.S., we're actually learning from the Canadians and a lot of the efforts that people have focused here, but this will continue to grow worldwide. Also use heart failure as a paradigm case, because if you think about heart failure and the complexities of it as a chronic condition, from biology to healthcare delivery, if we can solve that case, there's a lot we can do in healthcare. And then talk a little bit about effectiveness of care. So a lot of times we just have a study, it gets published in this nice journal in the Boston area, and then we think that's it. And maybe there's something else that we should actually learn from and understand, are we as effective in our care? And then a few ideas in terms of the perspectives on the solution, and finally, how things are coming together in terms of increasing emphasis on the value of healthcare, business intelligence for healthcare systems, which actually some of us would actually call research, and also this thing that sometimes we forget about, which is called the patient, that we still need to remember. So the good news is that the world's still growing. So if you think about just the population and demographics that are changing worldwide, and the population over 60 years old is continue to grow, and for a lot of reasons. So certainly because of public health efforts, but also because of efforts in terms of treating earlier conditions such as hypertension, as well as treating conditions like acute myocardial infarction. But we still have to remember that there are a lot of pathways that lead to heart failure. And so this will be an increasingly challenge worldwide, and especially in countries like Canada and US. Now, the bad news, or maybe good news, is that the expectations is that even though the burden on taking care of these large populations is going to continue to grow, the expectations are that we should just be more efficient. The output in terms of healthcare providers is largely flat. And you can look at this in terms of physicians, nurses, etc. We're not training enough health staff. That's disproportionate compared to the population growth, and also the population growth for a variety of conditions, including heart failure. And same way in terms of access to care. So whether it's bed access or other clinic access, that's also largely flat. And so here again, we either need to be more efficient, have more preventive measures, have different healthcare models for delivery of care, so we're not dependent on the usual construct. And this is the same across the globe. These are just examples across different countries, largely showing that the access to doctors and beds are the same regardless of the country. Now, this is where I'm actually sad to say that Canada may actually be a little bit better than the U.S. So when we're only recognizing this in terms of the value of care, but and when you look at overall life expectancy versus spending, it's actually pretty interesting in terms of how countries plot along this curve. Unfortunately, the U.S. stands out here, and it continues to drive important decisions in the U.S. in terms of how we actually think about the future of healthcare, but actually it's become a larger issue in the U.S. in terms of really it's an economic issue now. And so, but those pressures remain across the globe in terms of countries' perspectives and how they are handling this growing population that will need to be cared for as they get older. So this is the last year of Dr. Obama. There's been a lot of discussion about the Affordable Care Act, or Obamacare, and certainly that's probably going to be one of the things that history will highlight as one of his major achievements, and depending on your perspective, something else. But certainly it's left an impression on the U.S. that is going to be long-lasting. And this really came about. It was certainly the kind of interest in taking care of people, but once it translated into an economic problem where things are going to be crowded out in terms of education for children, other aspects of the economy, that's when it really hit the fan in terms of this problem has to be solved. And so if you look again at heart failure, being the paradigm case, over $30 billion in the U.S. in terms of costs, and estimated to grow to $70 billion by 2030. And so this, by far, is a important example of how things have to change in the overall healthcare, and then also specifically around cardiovascular disease. Now, there is a lot of interest in what will Trump do. So I just want to prepare you all that you may have a lot of extra friends if Trump wins the election. So there is multiple websites in the U.S. That people are signing up to, essentially how to transport themselves across the border to Canada if Trump wins. I certainly should not bring politics into this, but nevertheless, we'll go ahead. But Trump, he's a very smart guy. He recognizes that, look, it took $5 billion just to create a website. He was going to just hire a couple of teenagers, and it'll cost him $3. And so those kind of principles, he certainly should be able to handle the healthcare problem. Now, I'm just going to argue, just for the next 40 minutes or so, that may not be the right answer. That we won't be able to have a reality TV show where people come up and say, we're going to do this, and then have that transform healthcare. We actually may need a little data to drive healthcare decisions and actually understand what's the best way for heart failure. So there are a couple of themes that I want to bring up in terms of heart failure, and I think it lines up with some of the discussions that have already happened today, as well as what we see on the agenda tomorrow, is a simple fact. This is just a case example from Duke Hospital, Duke North, and a 60-year-old gentleman who has a history of heart failure for a long time, had 3 weeks of gradually worsening symptoms, blood pressure 100/60. You can see here, this is an example of what his heart looks like in terms of pathology, but the X-ray and echo show a dilated cardiomyopathy. Now, in contrast, an 80-year-old woman with a long history of hypertension all of a sudden gets short of breath and has flash edema, blood pressure 185 or 120, and quite thick. So these may be two different patients. They're still called heart failure, but maybe they're two different patients, and maybe perhaps we should be treating them differently. And how do we actually understand them, and actually how do we understand patients like them that we should treat better as we learn from each patient that comes through? Now, if you go on, like, you could think about different scenarios about similar cases in terms of how we treat those patients, and actually do we have systems of care to actually ensure that we are treating the right patient with the right drug at the right time and have the right follow-up. And so an example, another one with a 70-year-old gentleman, similar dilated cardiomyopathy, creatinine 1.5, potassium 4.5, gets started on spironolactone, and then follows up in 2 to 4 weeks is what he's told to do. Doesn't actually have a follow-up appointment scheduled. Doesn't even have a lab scheduled. So he could be at risk for hyperkalemia, but we don't really have a check for doing that. And he gets readmitted with a K of almost 7. An 80-year-old, similar thing, gets started on with hypertension, HFpEF, and started on metoprolol. She gets readmitted for severe bradycardia. So what are we doing through that vulnerable stage as they leave the hospital to ensure that they're safely going home and are safely at home? Another issue is we've had a long history of understanding that heart failure exists. This dates back hundreds and hundreds of years. But our phenotyping of patients is not necessarily any better. This famous guy here noted that heart failure, considered the abdomen fills with water, the feet and legs swell, the shoulders, clavicles, chest, and thighs melt away, respiration rare and large, the heart palpitates, has difficulty breathing, orthopnea as a result. So this is the same type of descriptions that we often give in our H&Ps right now. So how far have we advanced? Shouldn't we have something else that would be more of a phenotype of our patients? And another example, so New York Heart Association classification. It's been around for decades. Again, pretty blunt instrument for phenotyping of heart failure. So I think this is one of the opportunities that we have here in terms of actually having better descriptions of these patients and being able to target their therapies and understanding of their conditions. Another thing is that we don't do a very good job in terms of understanding as a population how we're caring for these patients. And even when we think we're kind of so-called successful and changing things, I'll argue it's relatively modest. So we actually have all this data, for example, in the U.S. on Medicare patients, so the largest cohort of patients with heart failure. And when we look at it, we can show in large numbers that yes, we've had some improvement, but again, going from a 1-year mortality of 32.5 to 32% is probably not enough. It generates a large p-value that's really small with a lot of zeros, but that's probably not enough of what we need to do. And so as healthcare systems, do we actually have the same ability to understand the population that is walking through our doors? And how do we understand that they're getting better with our treatments? And even when we look at back of the envelope, ways of simple guideline measures for heart failure therapies, you can start thinking about, well, look at each of the relative risk reduction, mortality, the number needed to treat, etc. And if you were to do the simple Trump math, it adds up to over 124%. That's actually like reincarnation. But nevertheless, it turns out like if you look at the variation in practice in terms of these therapies, we're not getting the biggest bang for the buck that we should, and that's not even counting newer therapies, which I'll touch on. So this week we had our monthly review of Duke Healthcare and heart failure, and so every time we go into that meeting, we think we walk in the door saying we're the best because we're Duke, and so and it's always humbling walking out of that door, realizing yeah, we're Duke, but we're probably just as average. And we're always asking questions like, well, it's this and that. It's these patients that come from some other service. They come from a different state. All these excuses, and then we go and look at it. It turns out it's that certainly there are patients that come from a lot of places, but even the patients that we care for at Duke still have the same problems. And so here's just an example. Certainly we're doing okay on therapies that have been around for many years. But then there are therapies like aldosterone antagonists that, even in eligible patients, we're still not doing as great. And then when you look at other aspects, it's still. And so the question is, and for certain awards, people have a so-called 50% performance rate. Is that really passing? Like, shouldn't it be higher? Shouldn't we have a higher standard? Shouldn't our patients deserve more? So, and if you think about this, it should be logical that as we translate guideline recommendations, that this can actually improve care and outcomes. And so this is a nice paper that showed that every 10% improvement in heart failure guideline therapy was associated with a lower odds of mortality. So just given what we have at hand may be important. Now, that's actually a really interesting time in heart failure. There's a lot of interest in heart failure with new therapies, newer understandings. And the question is, will we be better in the future? Will we be able to deliver care, evidence-based care, faster than it takes normally, which is 17 years? So if people remember, Institute of Medicine report in the quality chasm noted that for our cardiovascular therapies, on average, it takes 17 years before it gets into practice. And just to highlight a couple of examples, I mean, the growth and interest in device-based care has been enormous. The CardioMEMS device is certainly interesting in terms of actually tying in hemodynamics and therapeutic changes and potentially outcomes. And when you actually look at the results, it's pretty impressive. So reduction in all-cause hospitalizations, that's pretty impressive. That's something that some people would say it's unexpected. The combination of death and all-cause hospitalizations, that seems a good thing. From a patient perspective, those would be two things that I think they would care about, living longer and not being in the hospital. But how do you translate this evidence into practice? Certainly this is a complicated therapy and does take some resources to do that. And what about this? I'll be interested to hear how things are, what is happening here regarding implementation of Paradigm HF. So if one were to ask beforehand, you found a therapy that beats standard of care, shouldn't that replace standard of care? If you ask a patient that, they'll say yes. So that's what they expect. But what's the challenges? What are the barriers for that? And so certainly there are a lot of zeros in this p-value, and what are the challenges for translating that? So one thing, just talk a little bit about effectiveness of care, is that one of the arguments about paradigm is that certainly it's very impressive results, but it was a very selective population. And so I think that's a fair argument. So we do need to have some understanding about the effectiveness of care, so we actually can understand what are the populations that are not having the benefits as expected, or what are the issues that need to drive better benefits and translate the trials into practice more effectively. And when you think about it for the heart failure case, it's pretty well understood that the patients that we treat are often different than the trials that we use. And so our patients are older, they have more comorbidities, they have more complications in terms of their socioeconomic status. So it really is important to understand how do trials translate into practice, and do we have systems that will do that as well. So, and that comes up especially when we think about the complexities of care. So years ago, there was 3 simple therapies. Now, there's a list. How do people make choices, especially if they just get diagnosed with heart failure? And how do we know which therapies in which order, for instance? And for the right patient, shouldn't we know whether they would be more suited to one therapy or another? Especially if they have all these different alternatives. And an example of some of the challenges here to understanding the translation of efficacy and effectiveness is the story around MRAs. So clearly beneficial from the clinical trials and severe heart failure, post-MI, mild heart failure, mineral receptor antagonists are highly beneficial. But when you actually look in terms of what's happening in practice, it's quite interesting and somewhat unexpected, I'd say. So we looked at this, looking at what the guidelines linked to Medicare claims to look at longitudinal outcomes. And what we saw was actually surprising, that there wasn't any difference in mortality for this population. And certainly there are caveats because it's observational, and there could be residual confounding and also selection bias that we still cannot control for with even best analytic methods. But there was an issue here that we did see, which is interesting. We did see some difference in terms of heart failure readmission. So that's reassuring that we saw some benefit that was expected. But the concerning thing was hyperkalemia. Even though it's in the label, like this is a known issue, we still see higher rates of hyperkalemia early after admission that probably could be prevented, or have some type of system to actually understand and early on prevent a readmission for hyperkalemia. And it seems pretty clear, at least in the ACC/AHA guidelines, what to do. It's somewhat prescriptive. You started something anew, within 2 or 3 days, you should check the potassium levels, check it again at 7 days, check it monthly for at least 3 months, then 3 months after. So when patients go home with Coumadin and for AFib, we're programmed to check an INR. We're not programmed here to check a potassium level. And when we actually looked at this, linking Medicare data to LabCorp data, which is a national lab in the U.S., it turns out, patients who are in the hospital, they get their potassium checked. So over 90%, that's appropriate beforehand. Early afterwards, 13%. Afterwards, in terms of all appropriate checking, 7%. So that's extremely low. We should be able to do better than that. So there are a lot of reasons that people may consider this a problem, but it comes down to are we matching the right treatment for the right patient? Is there a treatment gap or the failure to implement a guideline-directed heart failure therapy? Is there failure in guideline-directed therapies to improve real-world outcomes, an efficacy effectiveness gap? And in some cases, maybe there's just, we don't know what the right therapies are yet. So we still need to address these kind of questions as we move forward and actually learn as we go along, as opposed to just assuming that we're giving the right care. So just to move on to a couple of thoughts on potential solutions. Well, one of the things that's probably we don't do enough of is just steal the best ideas. So Steve Jobs was well known as being an entrepreneur and is considered highly creative. But he was also well known that he stole a lot of ideas. He made them better, but he clearly stole ideas from the mouse, etc. So his quote of "good artists copy, great artists steal." That's something that we should think about in heart failure. Like, how can we steal from other areas to make our health systems and patients better? And he was well known to say he was shameless about stealing great ideas. And so we should steal from not only other disciplines, but we should steal from each other. So we should learn what is happening somewhere else and be shameless if it's working there to try it out at your place, and how to test it, evaluate it, see if you can make it better. And if you do, then share it with someone else. And if you look at other areas in terms of what they do, what their business model is, and in particular, I'm fascinated with things like Southwest. You know, if you were to ask a patient what they would care about, well, you know, they have a lot of things that they would care about. You know, they want to have predictable care. They want it to be high quality. They want it to be timely. They want it to be trustworthy. They want it to be usable. So, I mean, Southwest has in their mission essentially that they want to be trustworthy, where passengers know when to expect their flights, that they get there on time, that they get there safely, they get there with all their baggage, and there are no hidden fees. That should be the same thing for patient care. And you look at other examples in industry that's the case. And one of the things that's quite fascinating that they do is something called experiments. They actually do randomized trials. They actually look in a way to see how they can do better delivery of their services through experiments and randomized trials. So Google is probably one of the most famous companies to do so, because they realized a while ago that it's hard to make inferences solely with observational data. And so they're constantly doing things and randomizing to optimize an outcome. Turns out the outcome is revenue, but they're always doing randomized trials to optimize that in terms of their search functions. Facebook does the same thing. And so we should consider doing that in heart failure. The other thing is we are accumulating lots of data. And again, in industry, they're also taking advantage of this and trying to find unique unknown correlations and that would be identify different aspects to focus on. And so groups are starting to do this as well in healthcare. And one of my colleagues who's was as a fellow, who's now at Yale, he looked at this in some of our data sets. And so in a study called HF Action, he looked at, did a cluster factor analysis and actually identified 4 different clusters that have different descriptions. So one that was older, Caucasian, another was younger, obese, another that was more ischemic, and then another that was had a higher proportion of females. But also looked at different things in terms of how they their functional status as well as other biological markers differed. And so he was able to find different clusters of patients. And importantly, he was able to find different outcomes as well across these clusters. Now, the next step is really to see if there's anything different that can be done for these different clusters of patients and have a more precise medicine for them. The other thing I just want to talk on is about quality interventions today. A lot of times what we're doing is we tend to protocolize medicine and think that's just quality. And so that certainly can reduce variation. And so you can get more precise delivery of care. but you could be precisely wrong. And so if there's, within a standard of care, different types of protocols or different strategies of care, I think we should probably know which is the right strategy, and not just be so focused on giving the same care, but actually giving the best care. And so there is this need to actually do quality improvement interventions that address this, the transition between the hospital and clinic, and actually know what's the best model of care. And this is where we're starting to see this collision between clinical trialists and outcomes researchers, and doing pragmatic research, where we're actually deploying randomization in clusters or quality improvement strategy trials, and then actually learning what should be the next approach for healthcare delivery. And there's a lot of reasons why combining these into doing pragmatic research more often is going to actually be more helpful, especially as it's easier to translate the results into practice because you're operating in the real world. One example where we took this on was we actually randomized hospitals and Get Wealthy guidelines to essentially personalize site performance feedback. So when we did this, it was right before or right during the time of the recession in the U.S. And so one of the things that we learned from that is actually when health systems are under pressure financially, who do they fire first? Quality champions. So they don't generate revenue, they do generate cost, and so they go and get to do other jobs. And so when we were doing this, we found no difference between our personalized site performance report and consultation. And partly we didn't have the champions locally that we could have used, but also maybe we were missing the boat in terms of intensity, as well as this thing called the patient, which was not the focus of this study. So we're actually going to start a new study here shortly, which has been named by patients and investigators here, Connect HF. And so this is going to be a cluster randomized trial where approximately 160 hospitals will get randomized to a quality improvement initiative. And the quality improvement initiative will have two features. One will be a direct, intense, and personalized healthcare system intervention. So it will incorporate a lot more intensive health system feedback, as well as integration for different tools. And then another aspect is actually going to be patient-facing. And this will be what we call digital, and that will characterize it as more moderate in terms of intensity, but will incentivize, hopefully, good patient behavior and self-management. And then we'll follow up on outcomes that includes clinical outcomes as well as satisfaction and quality of life. The digital strategy is nowadays even older patients are starting to have smartphones. And then if you think about certain socioeconomic demographics, it turns out that they have smartphones as well. So normally where you think about populations that may be harder to reach, there are certain populations that actually will be easier to reach through mobile health technology. And so we're going to actually test this to see how effective it is in self-monitoring and self-management, heart failure, and then I'll facilitate education as well as evidence-based care. And the direct engagement, as I said, it's going to be pretty intense for on a national regional level, and also offer a medication management tool so that clinical providers can provide that to their patients. Just one moment about the digital strategy is that there's almost an app for everything. And so we do need to actually understand and test the effectiveness of these applications and seeing whether they work. And so we're actually doing this in a way where we're co-creating the strategy with patients. So like a few weeks ago, we had a patient panel where we shared some of our ideas in terms of these digital apps. And so one example that we had was that it turns out that, that people are addicted to their phones. I don't know if anyone in this room during any talk, actually looked at their phone, Facebook, email, Twitter maybe, whatever. caught a score, I don't know. But my guess is someone did look at their phone even during this talk. So, and so the concept here is actually a loss aversion. So as a patient doesn't follow lifestyle modifications, their steps, their routines, their medication adherence, you start turning off apps. So you start turning off their access to Facebook, their access to different things, and you can ultimately turn off their phone. Now, I tried this with my kids, and it caused complete havoc. And so I know it can work. But the one issue that our patient panel told us was that that's a big problem to turn off their phone because, for example, one grandmother, she said her grandson calls her every day to check on her. And so if she wasn't able to receive that call, he would worry about it. And so she really did not like the idea that if something happened and she, had her phone turned off, that she'd be cut off. And so we're still working through the details, but again, you can see that behavioral economics actually may be powerful if we can deploy it in the right way. And also these applications, if they actually work, they can be highly scalable. But the key question is, do they work? And so we need to actually test that out. So I'll turn to a little bit about kind of some of the future that is happening actually right now as people and health systems are looking at the value of healthcare and actually trying to integrate so-called business intelligence, and where we actually may be able to align as clinicians, researchers, and actually align with patients to bring these things together. So the good news is that there's data everywhere. So everywhere you go, people talk about big data and it's where it is and how it can be used. And so we're seeing electronic health records everywhere in ambulatory settings, inpatient electronic health records, data and claims are being connected to these health records, prescriptions filled, prescriptions that come out of pocket, public health clinic. And so there's data everywhere. But one of the things that we need to understand is how good is it? How do we combine it in a way that actually makes it useful? And so thinking about the values that going back, what do we expect for a business model for healthcare? Shouldn't it also emphasize those same qualities or values here? Make it usable. So I'm going to highlight an example of this that's starting off in the U.S. called PCORnet. So the Patient Centered Outcomes Research Institute was formed as part of Obamacare, or the Affordable Care Act, and its biggest investment is to take on the challenge of uniting all these different health systems or electronic health data with patients and clinicians. And so with about $300 million, they're doing this with a number of health systems and patient groups. So PCORnet's aim is to be a large, highly representative national patient-centered clinical research network. And the vision is really to do large-scale clinical research that is better, cheaper, and faster, that actually delivers answers that matter the most to patients, and actually does it in a way that reduces redundancy in the system. Because right now we have a system where we literally have electronic health records on one side where a study coordinator, for example, is looking at that and then cut and pasting results from that EMR to a case report form on another screen. That seems highly inefficient, and perhaps something could be different. And so the mission is to leverage and pull these systems together to actually allow people, and when I say people, actually patients, clinicians, health systems leaders, to make better informed decisions. So the way this is working is that at least initially, there's these 20 patient-powered research networks, which are composed of patient groups that have a condition or an interest in a certain aspect of health. And so there's an example for cardiovascular health, a patient-powered research network called Healthy Heart. And so they have a mobile platform that people can sign on to understand and improve their health. And then there's 13 clinical data research networks, which are composed of 2 to 12 health systems, and generally large health systems that come together. And so this becomes a network of networks, and what we call PCORnet. And through this network, it covers every state in the U.S., including Alaska and Hawaii. It doesn't cover Canada yet, but maybe we'll get there with some good help. And if Trump wins, everyone will leave to the U.S. and we'll bring PCORnet along. So we're actually just in the launching phase, and so we're actually going through the final quality checks of these different data systems. And so it's pretty interesting seeing what the population looks like. So who is PCORnet? And so we're looking at this now and seeing that, well, it actually does meet the goal. It's highly representative of the expected U.S. population. It goes from the teeniest babies to the oldest of the old. And then, importantly, becomes a large reservoir for doing observational research, as well as the ability to reach out to patients who say they want to be part of trials or want to be part of studies. So over 30 million that potentially could be part of clinical trials. And this translates into about a population of about 110 million that can be studied among 60 or more health systems. So the way this works is that every electronic health record system that's deployed is actually different. Even if it's Epic, it's different as it's deployed. And so all these different health systems have mapped their electronic health data into what we call a common data model. So in the blue circles is what's common to all the systems. So demographics, conditions, procedures, encounters, lab results, prescribing, that they've mapped to this common data model. For different studies and for different health systems, then they can also add different elements to it, including biospecimen genomic data, and then other things in terms of patient-reported outcomes, et cetera. And so this becomes the foundation for doing research in PCORnet, and hopefully not having to rebuild things over and over. So how many times does a data system have to be recreated every time? One aspect of this is that we want to protect privacy, and so data stays in the health system. And so we don't want data to electronic health records, for instance, leaving the health system without consent. And so health systems can analyze their data, and so as the data stays in the health system, we can actually generate queries that go into the health system and report back aggregate results. And so as we're launching this, which will happen in July, a researcher could be a clinician, an investigator, a patient, a group, a funder, will generate a question. And they'll ask that question and send it through what we call the front door. And that question actually gets translated into a SaaS program that can be distributed to the network and go through the firewalls of the network into the health systems, and then it's run against the common data model on these data marts. That query or that program then returns aggregate results then that are able to get pulled and then be able to get back to the researcher. And so we've left the data where it should sit inside the health system, but we're actually generating answers that go out to the world. And we're seeing or hoping that this will drive a lot of interest to actually understand, what studies should be done. So actually asking feasibility questions, but also how to engage patients and clinicians to co-create studies that would matter the most for their care. And then, of course, observational studies in a variety of ways. But I think one of the things that will be really important is actually doing interventional studies. So clinical trials that are more efficient, using e-identification, so taking the 30 million and finding either the needle in the haystack that you need to focus a population that has a rare disease or a common condition that you can reach out in a large way, and employing new ways for doing trials like electronic consent, electronic randomization, and electronic follow-up for a complete outcome. And then health system studies for actually doing strategy trials like cluster randomization. So in the last few minutes, I'm just going to highlight our first pragmatic trial. It's called Adaptable, and it's studying aspirin dosing. Now, people may think in this room that, well, aspirin's been around for years, actually 100 years, and what a boring question that could be. Well, it turns out that if you just look at the value of information for actually understanding the aspirin dosing of patients with heart disease, 81 versus 325, that you could actually learn something about what's lives saved or MI saved or bleeding events, because higher dose, higher risk of bleeding perhaps, but maybe less efficacious, lower dose, perhaps a less efficacious, lower bleeding risk. But we don't actually really know. And so this can translate to actually thousands of lives really in terms of every year if we actually knew that answer. And the way we're doing this is actually thinking about, how could you translate something in a traditional trial to a new world with electronic health records and a system like BeCoreNet, where you actually identify patients electronically, you reach them out electronically to consent them, and then you actually ask questions about their consent to make sure they're informed, and you do a complete outcome ascertainment because of events that happen in the health system. And so we just started enrolling about 10 days ago. The first patient enrolled at home at night on his iPad. I hope he didn't have a lot of wine, so he had appropriate consent, but he did answer the questions that confirmed he understood the study, so we actually did something more than most consents do. And so we plan to enroll about 20,000 patients where we electronically identify them, electronically screen them, reach out to them electronically, and then consent them and do their data collection. And so we'll also collect patient-reported outcomes through this web portal, and then as a backup system, we'll also call patients if they don't interact with the portal. And then we'll be able to capture their outcomes as they enter the hospital. Those are events that we'll be able to capture through the common data model. And so this is just an example where a simple question, if we can do it on a large scale, can actually translate into a public or population health benefit. And here's just a screenshot, and if you guys want to ever play around, you can go to adaptablepatient.com, and you can actually go through the video and what the consent process would actually look like. So anyway, those are things that at least I believe will be potentially useful as we start thinking about systematizing healthcare as well as research. So just in conclusion, I think everyone recognizes in heart failure, changing care is hard. Improving outcomes may be even harder, but we need to do it. There are things that need to be recognized, that people, patients, clinicians actually want more information. What's the right care? What's the right time? What are the right outcomes that we should be targeting? And how do we deliver those outcomes that matter the most to patients? And how to get there is, may be difficult, but actually the forces are aligning. That we are seeing now the increasing systemization of care delivery, research, that maybe that allows us an ability to have a platform to better phenotype patients with heart failure, to better address their questions efficiently and effectively, actually to put the patient back at the center, understand what they want, and then drive answers towards that. And then actually follow the evidence as it goes into practice. Are we actually doing it? Are we doing it right? Are we doing it in a timely way? And are we doing it equally across populations? And then follow and see if we actually can make a difference in changing outcomes. So I'll stop there and really want to thank you for having me here. It's always fun to come up to Canada and see how the good life is. There may be a lot of us here soon, depending on what happens with Trump. So thanks.
Thank you very much, Adrian. We have about 3 or 4 minutes for a couple of questions. So if there's anyone do we have microphones? We do have roving microphone microphones in the audience. So if you want to ask a question or make a comment, please stand up and they will find you. Just while we're waiting for that, I would point out to you, Adrian, that I'm sure that any refugees that would be willing or wish to come after the election, we have a recent history of of very generous offerings to refugees of all types from any type of war-torn country. So, so I think the prognosis is very good from that point of view.
That's good. Well, I'm not sure I'll get used to the winter though.
I do have a question. It's about the MRAs. That's a unique problem where the evidence was, I mean, very overwhelming. Studies stopped early, and not just this, a couple of publications that you mentioned, but it's been repeatedly shown problematic to show any meaningful benefit on an effectiveness perspective, and perhaps it goes back to the actual implementation of it in the mechanics of starting and the lack of follow-up. Do you have any comments to make as to how you might be able to show effectiveness of a very powerful medication like this?
Yeah, so I mean, there are a couple of things that could be considered as issues. One is that we may wait too late for using it. So actually, one of the things that even though we try in all these different studies to account for the severity of illness, it could be in patients that have such severe heart failure that we're waiting too late. And so and we let eligible patients go by that don't actually get the therapy. And so that may be one reason why we don't see as effective. Certainly not having the systems where we kind of have the automated checks, just like we would for an INR. Why shouldn't we have that for patients who get started in MRA? And then there probably are patients that they don't benefit, but we don't actually know how to identify those. So,
yeah, pretty good. Perhaps one more. In Canada, we have oh, is there one in the back? Go ahead.
Yeah, Mike Farkouth. Adrian, welcome to Toronto. I just have a question, Adrian, about linking to pharmacy data, because there's a lot of reporting now that, especially in the U.S. with Walgreens, CVS, the large pharmaceuticals. Have you been able to do that in the PCORnet, and is that a plan?
No,
because that seems to be a really
that's a great idea. So there have been different forms to attempt that, but and again, there's I guess one good news of the various consolidation efforts that allows some greater ability to do that, but that hasn't been done yet on a large scale. So like it's been kind of piecemeal, I'd say, and not in a systematic way. So,
just raise your hand if there's a question. I already missed one. There we are.
Hi, Pat McEwen. It's more of a comment than a question with the angiotensin inhibiting drugs. They are difficult to start. They need a great deal of monitoring. And I don't think there's enough emphasis placed on modulating the drugs during intercurrent illnesses. So heart failure, particularly advanced heart failure in the elderly, patients have intercurrent problems. And there isn't enough advice about what to do when the patient gets flu and dehydrated. And so I wonder whether the data isn't confused by the fact that these are very sick patients, and you can't send them off on their spironolactone and see them in a year. It's, I think, underestimated the complexity of monitoring these patients.
I think that's a great point. I mean, one of the issues that comes up is actually for many of these therapies, we do it and we study in chronic, stable outpatients. But when we generally start new therapies, is often an inpatient, and we don't necessarily have as much information as we'd like to know is that the right time, or when's the right time, et cetera. And certainly in the context of acute heart failure, where things can be dynamic, we don't really have the great answers for that. So. But there's actually at least one trial that's going to start up, at least with LCZ or valsartan sacubitril, to understand at least somewhat using that in the acute hospitalization. It won't be as large as Paradigm, but that may provide some information there.